Thanks everyone for being here. I want to take the opportunity to talk a little bit about salvage therapies for localized prostate cancer. I'll credit Dr. Kundu with the title. He calls it Plan B. So when Plan A may not be succeeding, what do we do from there? The objectives is we're going to start out with a contrasting case review, and then we're going to talk about how we identify recurrences after initial local therapies, both the disease localization and then a prognostic assessment. And then we'll talk about salvage treatments of presumed recurrences, both after prostatectomy and also after radiation therapies. I'm, by the way, Ashley Ross. I'm an associate professor of urology here at the Northwestern Feinberg School of Medicine. So let's go to two cases that patients I've treated over the last several months. The first was an 80-year-old who presented to me with radio-recurrent prostate cancer. At age 73, he was diagnosed with stage 1 disease, and he was NCCN low-risk prostate cancer with 4 out of 12 cores positive, all on the right. PSA was 3.4. He elected to have brachytherapy. His PSA would nadir at 0.9 about 2 years after that, and then it started to consistently rise. He was seen by one of our medical oncologists, and it was noted that his PSA was rising to 2.5. And with the 3 consecutive rises, he thought we should try to restage him. An MRI, which is depicted here on the right, showed a 29 cc prostate. In the right peripheral zone, there was a lesion. It's shown there in the 3D reconstruction of the upper left panel. A lesion here in the right peripheral zone away from the urethra, also shown here. The CT and bone scan were negative for metastases. He was then referred to me, and we did a prostate biopsy to confirm the diagnosis. We did systematic sampling of the prostate, including the seminal vesicles, and including the target lesions that showed up on the MRI. This showed a Gleason grade group 5 cancer in that target lesion. The right seminal vesicle had brachytherapy changes, but was negative for carcinoma. So then we had a discussion. We discussed first what his life expectancy was. By the Social Security actuarial tables, he had an 8.43-year life expectancy. He was in the top quartile of his health, and so there's a rough behind-the-envelope calculation where you can take individuals like that and add 25% to their life expectancy, and that would give him about a 10-year life expectancy. We then said, well, maybe he would benefit from local therapy, potentially curative local therapy. His disease was greater than 0.5 centimeters from urethra based on both imaging and on my biopsy findings, and his seminal vesicles weren't involved based on my biopsy findings. So he was a candidate for salvage cryoablation, and we performed that as an outpatient. He tolerated that well. At 3 months, his PSA is 0.3 nanograms per mil, and he's continent. Let's contrast this with another case. This is a younger gentleman, 62 years old. When this gentleman was 49 years of age, he was diagnosed with low-risk prostate cancer, and he elected to have brachytherapy. His PSA would nadir and then start to rise, and this was about 8 years after the initial brachytherapy. And he would have restaging. That would show no metastatic disease, but in the prostate, he had Gleason grade group 2 cancer and Gleason grade group 1 cancer. He then had a discussion with his radiation oncologist who treated him the first time, and they elected to undergo salvage brachytherapy after initial brachytherapy. His PSA continued to rise after that, and he had negative staging for distant metastatic disease. They did not rebiopsy the prostate, but he was started on Casodex with the idea that then he would start hormonal therapy and maybe do intermittent androgen deprivation. Very quickly after starting Casodex, he had severe depression and hopelessness. They continued the Casodex to see if that would persist, and it did. And they stopped the Casodex at 2 months, and they decided not to initiate androgen deprivation therapy. He did have a good PSA response to those 2 months of Casodex, with his PSA dropping to about 1.09, but 4 months later had risen back to about 9.2. He had an Oxymin PET in October, which showed no signs of prostate cancer. But his PSA continued to rise to 13. He saw one of the medical oncologists in our system, and they thought, let's do another Oxymin PET. This time it showed a possible recurrence in the prostate, no other distant disease. An MRI was also performed that showed a possible lesion in the prostate as well, and he was sent to me for a biopsy to confirm the disease. Biopsy of his prostate showed high-grade prostate cancer in virtually every core, including both seminal vesicles and including cores that were nearer to the urethra. So we talked about his case together. He had a life expectancy of about 20 years. He's 62 years old at this time. His disease was less than 5 millimeters from the urethra, and his seminal vesicles were involved, making ablative therapies difficult to elicit a cure. I told him he was not a cryoablation candidate for sure, given those findings, and we decided to undergo a salvage radical prostatectomy. He had an uneventful perioperative course. He was discharged from the hospital within 24 hours. After salvage prostatectomies, I leave the catheter in for 3 weeks, and I do cystogram on everybody. This is his cystogram shown there on the right. You can see that there's no leak. You can also see that there's a plethora of brachytherapy seeds that were just placed in the external sphincter and pelvic floor muscles. And then after that, he's done pretty well. At 1 month after catheter removal, he's regaining his continence, so actually a little bit better than I expected. He's down to about 1 to 2 pads per day. His pathology showed T3B disease, no lymph node involvement. He had a positive surgical margin both at the seminal vesicle and at the left base. He had cancer throughout his prostate and EPE throughout with bilateral SVs involved. We're still waiting for his first PSA. So that kind of brings us into the discussion tonight, which is going to be a discussion of recurrences after local therapy for prostate cancer. So recurrences after initial local therapy for prostate cancer, so when you're treating what you believe is localized disease to cure, actually are fairly common. In the literature, it's 20 to 50% undergoing radical prostatectomy or definitive quote-unquote radiation at 10 years. Those point estimates are actually probably conservative given the current clinical landscape. Probably we're close to 50%, maybe more of the patients will need more therapy beyond their first modality of treatment with longer follow-up. And this is because we're following patients with low-risk prostate cancer on surveillance, and the bulk of the patients that we're treating with prostate cancer are really closer to unfavorable intermediate risk or higher risk disease. So knowing that this is an inevitable issue that's going to affect many of our patients undergoing treatment for their prostate cancer, how do we define recurrence? How do we define that our first therapeutic approach may have failed? Well, let's look at that both after prostatectomy and also after radiation. After prostatectomy, the AUA threshold for biochemical recurrence, which still biochemical recurrence is going to be our first indicator of disease recurrence, is a PSA of 0.2 that's confirmed. Now, my belief is that we're in a different era now, that ultrasensitive PSAs are reliable and should be used. Although, there's still a lot to figure out there around ultrasensitive PSAs. One thing to figure out is that there is some noise at the ultrasensitive level, and where can we really be confident in the ultrasensitive PSAs? I think the threshold that was proposed by Sokol and colleagues a few years ago of 0.03 seems to have very good performance characteristics. So this is just some data from that paper. If we look at people who had their first PSA ultrasensitive being less than 0.03, their 5-year biochemical free survival is about 91%, whereas people with PSAs greater than 0.03, their 5-year biochemical free survival is about 27%. So what I typically do is I use ultrasensitive PSAs routinely in the post-prostatectomy setting. I will use them until the PSA gets to 0.1, and then I can convert over to regular PSAs if I want. But I think there's a high value of ultrasensitive PSAs. So how about biochemical recurrence following radiation? I think that the Phoenix definition that was revised by Astro and the Rtog makes a lot of sense and is very useful. It's a nadir plus 2 definition. Or consecutive rises in the PSA, so 3 above the nadir. Importantly, the nadir plus 2 definition is regardless of use of ADT or not. So if you used ADT and the person's nadir was undetectable, then your nadir plus 2 definition means PSA of 2, you should be suspecting a recurrence. It's also important to note that the Phoenix definition was designed to make comparisons between retrospective series, and it's really designed to identify meaningful recurrences that would often lead to metastatic events. And so, you can use a lot of your clinical expertise. Your antenna can be up with patients that you might suspect. And certainly, I think adding to the nadir 2 plus 2 definition by consecutive rises makes a lot of sense. We saw that in our first patient scenario that I presented. So just some additional considerations when thinking about biochemical recurrence following radiation. In brachytherapy patients, at 5 years, the PSA really should be less than 0.7 to be confident that a cure has been elicited. Another point, although it's seldomly used outside of the context of clinical trials, a biopsy at 2 years following external beam radiation, even regardless of what the PSA is doing, can be very predictive of recurrences. But again, this isn't used that standardly in clinical care. So what is the workup? And now with that in mind, what is the workup and treatment of someone with potentially recurrent or persistent prostate cancer after an initial attempt for cure by local management, whether it be surgery or radiation? So this was like one of the most important things of the talk. I'm going to have a couple slides on it because I want to emphasize this point greatly because I often will see patients where this hasn't really been the case. So early evaluation and management decisions is paramount and allows for potential cure. And I don't really mean early in terms of temporal time as much as like early in terms of like disease burden or PSA levels. So the PSA at the time of salvage is highly, if not the most prognostic factor for long-term remission. It's true with salvage radiation therapy following radical prostatectomy. It's true with salvage prostatectomy following radiation. It's true with salvage cryoablation following radiation. It's true for salvage HIFU following radiation. So we want to monitor our people in their survivorship carefully. We want to consider salvage treatments early and not wait until the disease is incurable. As a rule of thumb, if it helps you remember, you want to be initiating a salvage therapy if you're going to do so after radical prostatectomy at PSAs less than or equal to 0.4. And for salvage prostatectomy, and after radiation therapy, you want to be initiating salvage therapies at PSAs less than or equal to 4. Then after those thresholds, you're really losing opportunities for cure. So let's go through some of that data just to drive this home. You've done a prostatectomy on a gentleman. You know that because you're surveying your low-risk guys and you're really taking intermediate and high-risk men to surgery, that there's a high chance of recurrence. And so you're monitoring them carefully. And what you want to do is make sure you're referring them to radiation therapy if needed when the PSA is not too high. This is a large series of men treated with radical prostatectomy, and it's stratifying them by what were their outcomes based on what their PSA was before they got their salvage radiation. In the darker blue line is salvage radiation given before the PSA was 0.2, yellow 0.2 to 0.5, and then the other lines below. And the best outcomes are seen with the lower PSAs, both in terms of freedom from biochemical-free recurrences and also in cumulative incidence of metastatic disease shown on the right-hand plot. You can see that if the PSA is less than 0.5 at the time of salvage radiation therapy, they're going to have significantly less incidence of distant metastatic disease. Same thing for the biochemical-free survival. The same holds true in your post-radiation patients. You've treated the patient with external beam radiation or brachytherapy and you're monitoring them. Take the Astro guidelines seriously. Follow those patients. When they get to a nadir +2 or consecutive rises, they really deserve a workup and an opportunity for cure of their disease. This is a smaller series of people undergoing salvage radical prostatectomy after radiation. And you can see the top line is men treated when their PSA was less than 4 at the time of salvage prostatectomy. They're doing astronomically better in terms of disease progression-free survival compared to people who have PSAs between 4 to 10, and certainly from patients with PSA greater than 10 that are rarely cured by salvage therapies. Same thing holds with salvage cryoablation after radiation failures shown on the left and salvage HIFU shown on the right. Your 5-year freedom from recurrence is about 60% when you have PSAs less than 4 and you do salvage ablative therapies after radiation, and it's like 14 to 22% if the PSA is greater than 10. So monitor your guys carefully. Give them this opportunity for cure. Don't let their disease progress to an incurable state. And again, why, what are we talking about here? It seems so obvious, but so many times do I see patients come to my clinic, like the second patient that we just talked about. When he first came to see me, his PSA was over 10, or even when he was first worked up for his first salvage, his PSA was over 10 in that young man. It's almost nonsensical to me. And what we're talking about is the likelihood of metastatic disease increases with PSA. Here you have PET PSMA on the left and fluciclovine scans on the right. And what you can see, this is in post-surgical patients, but I think it rings true in the post-radiation setting as well. You can see that as the PSA level increases, so does the chance that you're going to have multiple regions, including extrapelvic regions involved by disease. In fact, as we go from PSAs of under 0.5 to PSAs of 0.5 to less than 1, you see more than a doubling of the chance that you're going to have extrapelvic disease, either with PSMA on the left or with oxygen on the right. And I think that rationale that if they have a recurrence, it's inevitably metastatic. We can't have the second opportunity for cure, which I think a lot of us don't hold, and it's good that we don't hold it because it's not true, particularly for disease that we are diagnosing that appear to be localized clinically that we're taking for definitive managements. When those diseases evolve, they evolve from local to local, regional to metastatic in almost all the cases. And so there is a window of opportunity for cure. That window of opportunity is at lower PSAs, and we need to institute the appropriate workup at those lower PSAs. So now here's what is the workup and treatment. We'll start with post-prostatectomy, where it's a little bit easier, and then we'll look at post-radiation. How are we monitoring, guys? How are we doing the workup? Some notes of consideration post-prostatectomy. Restaging, even with PET PSMA, is not very informative at PSAs less than 0.2. Remember that the PET can't really see lesions that are less than 3 millimeter. You're often going to have a negative scan with the PSAs less than 0.2. A second thing to note is that PSA doubling time is not really well validated or validated at all at the ultrasensitive PSA level. And so we really can't benefit from watching a doubling time. And if we're watching a doubling time as they go from 0.2 to 0.4 or 0.4 and on, as I just showed, we're missing an opportunity to treat them when the PSA is low and have a better chance of clinical control. We do know that genomics, like the Decipher Genomic Classifier, provides independent prognostic information beyond the clinical pathologic features. So now, what's my approach as a urologist for my patients after prostatectomy? If they're PT2R1 or PT3 disease and they have a Gleason grade group of 1 to 3 at their prostatectomy, then what I do is I follow their PSAs. I still also use ultrasensitive PSAs, but I follow their PSAs until it gets to 0.1, between 0.1 and 0.2, and then I refer to the radiation oncologist. You might say, well, why do you do ultrasensitive PSAs if you're not going to make an action decision for those patients until it gets to 0.1? It's because I use it to decide my interval of PSA testing in those individuals. Then I refer them to radiation oncologist. I might get the genomic classifier Decipher score to aid in decision-making regarding androgen deprivation therapy. I don't routinely restage these patients because it's unlikely that I'm going to detect any disease at a PSA between 0.1 and 0.2. How about for my patients with seminal vesicle involvement or higher stage, or the ones that had high Gleason grade group of 4 to 5 at the time of prostatectomy? For them, I follow their PSAs until it gets to greater than equal to 0.02, and then I refer to the radiation oncologist. Here I use genomic classifier testing with Decipher to aid in decision-making regarding quote-unquote adjuvant therapy, but it's really more like early salvage, so that early salvage between 0.02 and 0.1. I do not routinely restage these patients because the PET scan is just not going to be informative in almost all of them when you're talking about PSAs between 0.02 and 0.1. So I'm going to go over this part just briefly. There's an excellent talk that was given in this series by Dr. Sajdev earlier in the year. I really encourage any of you that missed that to see it. But in these next few slides, I want to go over why do I do this approach? Why do I do what I do? So first, let's talk about the patients with the PT2R1 or PT3A disease, Gleason grade group 1 to 3. So the guy with Gleason 4 plus 3 equals 7 prostate cancer who had extraprostatic extension and a negative or positive margin, say, at prostatectomy. Why do I wait till they get to PSAs of 0.1 or 0.2? Well, there's 3 really well-conducted trials, Radicals, RAVES, and the Rtog AFU 17 trial that show that early salvage radiation at PSAs at around 0.1 or 0.2 compared to adjuvant radiation, which was radiating them before that, really had no difference. So you're probably over-treating those men if you treat them when their PSA is completely undetectable. So are there any men that would benefit from radiation before 0.1? I said that radiation I do consider radiation below 0.1 in some men, and in those men are the guys that have higher Gleason grades or higher stage of prostatectomy. The 3 trials that I just showed you were really enriched for patients that had T2R1 or T3A disease and intermediate risk prostate cancer by Gleason, intermediate grade prostate cancer. The minority of the patients were ones that had higher stage, higher grade. What can we say about those patients? Well, this is a retrospective multi-institutional study that Dr. Schaefer and myself were part of, where we took men where we had their clinical features and their genomic features and long-term follow-up. And we said, what are the things that predict that the guy would benefit from radiation when their PSA was below 0.1? And there were 4 factors that came out. They were higher stage T3B disease, obviously N1 disease, Gleason grade group, 4 to 5, and their deciphered genomic classifier. If they had just one of those risk factors, they really did not benefit, as you can see in the cumulative incidence curves on the left, from adjuvant radiation. But if they had more than one of those risk factors, then they did benefit from early, we can call it early salvage, we can call it adjuvant radiation, but radiation before 0.1. And so that's why I get the genomic classifier in those men, and that's why I follow them and refer them to radiation oncology early. Just briefly, how about the question of should we add on androgen deprivation therapy with radiation in the salvage setting? It's an interesting question. This is the Rtog 9601 trial looked at people getting salvaged after prostatectomy with radiation plus or minus 2 years of bicalutamide. And even though that trial showed an overall survival benefit, recently published subset analysis show that the overall survival benefit really was only happening in men with PSAs greater than 1.5 nanograms per mil at the time of salvage. And so the question was, well, why wasn't it helping, everybody? Well, it turned out that, there was an other cause mortality increase in men with low PSAs, men that I was telling you want to pull the trigger on early. Adding ADT was causing an overall other cause mortality increase. You could argue that, well, that's bicalutamide. No one's using a single agent bicalutamide. It's more morbid than ADT. The Rtog AFU 16 study, which was giving salvage radiation with 6 months of ADT, showed at 10 years an improved metastasis-free survival, but not overall survival. And again, it could have been because of some of the morbidities of ADT. So should nobody who's getting salvaged at low PSA levels get ADT with their salvage? I think the answer to that is no. There is a subpopulation that benefits from ADT with their salvage radiation, even when it's given at low PSAs between 0.1 and 0.4, for instance. And those, we can define those men perhaps using their genomics, which is why I was mentioning I get the deciphered genomic classifier. This is a subset analysis of the Rtog 9601 trial, where they had about half the trial population, 350 patients, where they had tissue to get deciphered testing on. And what they showed is when they looked at people with lower PSAs, below 0.7 at the start of salvage radiation therapy, if your genomic classifier score was low risk, those men had minimal oncologic benefit from adding the androgen deprivation therapy, but they were harmed by the androgen deprivation therapy. They had an overall survival detriment of about 8%. So 8% more of them were going to be dying earlier because they had the hormonal therapy. If you look at the people who had intermediate to high genomic classifier scores, you can see that in that situation, if they added hormonal therapy at low PSAs, they had not only a distant metastasis-free survival, a prostate cancer-specific mortality-free survival benefit, but also an overall survival benefit. So again, again, what I do is if my person has high-grade, higher stage disease, I'm referring them to radiation early before the PSA even gets to 0.1 if they have 2 of those risk factors. If they have lower stage intermediate grade disease, I'm referring them to radiation in what's the traditional salvage setting, 0.1 to 0.2, and I'm getting the genomic classifier to help my radiation oncologist and the patient and myself think about informed decisions about the addition of ADT. There's other trials that are ongoing in this area. They're also going to be analyzed with genomics, and we'll see how much this bears out. We've had a lot of discussion recently, and for some of you that were on the last oncology conference we just had, about PET imaging. And I was just telling you that, well, PET imaging is not very helpful when thinking about next steps after prostatectomy, because It's not going to show disease in most patients with PSAs less than 0.2. So when should we get PET imaging? Well, I think that PET imaging, PSMA or Oxman, is really most useful in two settings post-prostatectomy. One is imaging men after complete local control. So ideally, you'd have a guy undergo radical prostatectomy, you'd be monitoring them carefully, and you'd give them the opportunity to get salvage radiation therapy when their PSA was under 0.4. And now they've finished and they've had complete local control, in your opinion, but say their PSA is still rising. Now I'd want to get the PET scan to see if there's early detectable metastatic disease or even disease in the pelvis that may have been missed, and you can have therapeutic intensification there. I know that data is still evolving. We have some phase 2 trials that show the benefits of stereotactic radiation to those lesions. The other setting is, what if the person presents to your office and they had not been followed carefully, they had not had this lecture and had this bolded underlined statement by Dr. Ross that said, follow your patients carefully, refer them early to get definitive management, and they come and see you and their PSA is above 0.2 and they have not yet had salvage radiation therapy after prostatectomy. Here, I think the PET imaging is very helpful. It can help you with your treatment planning. We had recently reported results in the Empire 1 trial that was using fluciclovine that showed that failure-free survival was improved almost 30% by doing PET imaging and using it to help treatment planning in the salvage setting. This is an example of a patient on the right who had a PSA of about 0.3 after prostatectomy, had not had salvage radiation therapy. He was imaged with PET scan. I don't know if you can see my pointer, but in the upper right-hand panel, there's a small, there's some uptake in what looks like a lymph node. The original salvage radiation planning scheme was shown in the yellow on the bottom panel. This was modified to include that area in the blue, which encompasses that positive area on the lymph node. This obviously uptake, you can see the uptake that's down here in the upper right panel in the lower pelvis, that's just bladder uptake. Also importantly, when considering people who are getting salvaged, they're coming to your office, they haven't had salvage radiation, their PSA is very high, say it's 1.52 even. For those patients, if they have extra pelvic disease, at least in retrospective series, they don't seem to benefit from salvage pelvic radiation therapy. So if you can see data outside the pelvis, you're not often going to be helping them after prostatectomy by doing salvage in the pelvis. So now let's go on to talk about a more thorough discussion on workup and treatment of the post-radiation patients. So these are patients who have had, they've selecting between primary therapies, they selected to have brachytherapy or external beam radiation-based therapies, and now you're suspecting a recurrence based on their PSA going to nadir +2 or based on consecutive rises in their PSA. Again, you've been watching these patients carefully. You're initiating this workup when the PSA is hopefully less than 4. And then what are the goals here? The goals are you want to confirm the disease presence in the prostate after radiation. You want to confirm the absence of metastatic disease before you initiate some kind of salvage local therapy. You want to identify the location of disease in the prostate because it's going to help you determine what treatment modality to use. And around all this, you got to have a couple considerations. Imaging, I think, is very helpful, specifically MRI and PET imaging. But also you have to note that MRI and PI-RADS is not well validated in the post-radiation therapy setting. You can see that the first patient I presented in the case contrasting cases today, the MRI showed a lesion. The radiologist appropriately did not score it, but they did say, hey, that's a lesion you want to look at. And that was the area of positivity on his biopsies, systematic and targeted. By the same token, the second patient we couldn't tell what was going on in the MRI. They weren't really sure where disease was, and he had disease in every single core of the prostate and the seminal vesicles. PET imaging, very helpful. I use it primarily to tell me what's going on outside of the prostate. Do they have distant metastatic disease? Uptake in the prostate is not very well validated in the post-radiation therapy setting. You can see the second patient, again, had very little uptake in the prostate, lots of disease throughout their prostate. And I think a lot of this might have to do with tracer uptake, blood flow kinetics, and other issues. And so we'll get back to that in a second. So what's my approach then to the post-radiation therapy patient? So the patient has a nadir +2 or consecutive rises of the PSA. We're going to do some shared decision making. These patients are often older men often are are taken to radiation in the first place. So these patients often have limited life expectancy. So we'll calculate that. We'll do some shared decision making before we proceed with workup. But then we'll proceed with workup, and we'll do if they desire, and we'll do staging. A PET PSMA or F-18 flucyclovine is preferred in this setting. You can do a bone scan or a CT MRI if the PET is denied, but I strongly believe that PET PSMA and flucyclovine are highly preferred in this setting. They have better performance characteristics. They're more sensitive and specific. They are closer to the real truth than quote unquote conventional imaging, bone scan, CT and MRI. So then the second thing you want to do is, no matter what that staging shows you, I think it's useful to do a prostate biopsy, particularly if that staging does not show metastatic disease. If the PET scan does not show any uptake anywhere, you still want to do biopsy of the prostate because it can be misinforming you with a false negative in the prostate. When you do the prostate biopsy, you're going to sample the prostate, and additionally, you're going to sample the seminal vesicles. The seminal vesicles are often not treated by brachytherapy. Often it's difficult to treat the tips of the seminal vesicles with external beam radiation. You want to sample all MRI questionable lesions. You want to sample all PET avid lesions. So then what happens then? So you've done your imaging and you've done your biopsy. What do you do next? So say the imaging demonstrates distant metastatic disease. My general approach is they're not going to benefit from local salvage therapy. There are some question marks, but in general, they're not going to benefit from local salvage therapy. Say the pathology from the biopsy shows no cancer, or maybe it shows some malignant cells consistent with treatment effect. So, and it's kind of a wishy-washy pathological thing. I don't really know what that means. Then I'll do no local therapy, and I'll clarify with my pathologist as to whether they mean that there's viable malignant cells and a background of cells that have treatment effect, or whether they mean that these look like ghost cells and they look like they were previous cancer cells that are non-viable. The pathologists in my group at Northwestern are excellent, and they make it very clear on their reports. But when I've worked in other practices, I didn't always have that degree of clarity. So it's an important thing to clarify with the pathologist what they're actually trying to tell you. I'm hoping eventually we'll be able to do in questionable cases some molecular analysis, maybe with something like a genomic classifier or Ki67 or a CCP score, and see if these cells are proliferating or not in these questionable cases. But right now, that's not in their wheelhouse. So say there's viable localized disease detected by biopsy, and there's no sign of metastatic disease. Here, I consider salvage cryoablation as a preferred option if there's no seminal vesicle involvement or periurethral disease, and I'll talk to you about why in a second. I consider salvage prostatectomy as a preferred option if there is SVI or periurethral disease, or if it's really the patient's preference, or after a informed discussion. Honestly, I elevate this option a lot in younger men. Like the second man I showed you, obviously we're thinking about salvage prostatectomy because he had periurethral and seminal vesicle involvement, but also he was only 62. Other salvage options can be considered, and I'll talk about them briefly: salvage HIFU and salvage brachytherapy. I'll make a disclosure that I don't have any operational knowledge. I only have book knowledge of these therapies. I have not done either of them in my practice. So just to reiterate some points, because we see these things happen, or I see these things happen a lot. I'm going to go over the workup and treatment of post-radiation therapy patients, and I just want to highlight some do's and don'ts. Again, I want to reiterate, do follow PSAs carefully and initiate workup when the PSA is relatively low, less than 4 nanograms per mil. We do not want to identify missed opportunities for cure. Do perform staging to determine if metastatic disease is present. I prefer PET imaging. Do perform a prostate biopsy regardless of the imaging findings, and do sample the seminal vesicles at the time of that prostate biopsy. Do not initiate ADT therapy for men with curable localized recurrences. The ADT therapy does not synergize to increase the efficacy of ablative therapies such as cryoablation, but rather can make those therapies difficult, if not impossible, to perform, because often the benign tissue will respond to the ADT, but the malignant tissue won't, and now you're bringing that malignant tissue closer to the urethra. Giving ADT alone to men with curable localized recurrences is providing harm without benefit, so do not do that. Do not counsel patients that the treatment is worse than the cure in the salvage setting. Give them a balanced discussion. If you're not aware or if you don't perform salvage treatments, make sure they see a provider that does those routinely, because they need a balanced discussion. In fact, that discussion of telling them the treatment is worse than the cure in the salvage setting, that should be pervade to your initial discussion that we're having, particularly as urologists with patients, about surgery versus radiation. I think the old discussion of saying, well, do surgery first because you can't do anything after radiation, you can't do surgery after radiation. That's not really a whole truth. A better truth is to say, we're going to pick between these two good primary therapies. After surgery, radiation can be employed and it doesn't have that many side effects. After radiation, there are still salvage options. Yes, they will carry with them more morbidity than if they were used in the primary setting, but some of these salvage options, particularly salvage ablative options, can be relatively well tolerated. So let's go over these salvage options post-radiation. One thing that I found interesting in the literature, and obviously there's lots and lots of caveats here, but cancer control rates are relatively similar in the salvage setting, despite what you use. Salvage prostatectomy, salvage cryoablation, salvage HIFU, salvage brachy. This is a nice review by Dr. Nguyen's group, where they looked at this, and the 5-year recurrence-free survivals are all comparable. They're 50 to 55%-ish in their terms of their 5-year biochemical-free survival. Lots of caveats because they're not adjusting for patient selection. There's been no head-to-head studies. But salvage prostatectomy is not necessarily the gold standard in well-selected patients. This is a SEER Medicare review I'm showing here, and actually in this review, overall survival and prostate cancer-specific mortality favored salvage cryoablation over salvage prostatectomy. And the Medicare expenditures for salvage prostatectomy were, not surprisingly, almost twofold higher than salvage cryoablation. How about functional outcomes? The salvage prostatectomy appears to potentially be the most morbid, with severe urinary incontinence being between 30 and 90%. I think in expert hands, reasonable point estimates to tell the patient is 30 to 50%. Erectile dysfunction is pervasive across modalities. The modalities that appear to have the best continence control are salvage cryoablation and salvage brachytherapy. Again, numerous caveats. You can't really make head-to-head comparisons because there's a lot that goes into patient selection. It's just telling you that in appropriately selected patients, you can minimize urinary incontinence and other morbidities with still getting good cancer control rates. It also tells you that whatever modality you're using, the patient should expect that their cancer control rates are only going to be about 50% if you take all comers. But as I showed you earlier, if you're doing your workup appropriately and the PSA is less than 4, the patients should be expecting about a 70% cancer control rate with salvages after radiation. Another note is no matter what you do, a lot of these patients are coming in older, they're coming in with erectile dysfunction. A lot of these therapies are going to cause more dense erectile dysfunction. I would say that particularly, salvage cryoablation, at least in my hands, I'm often treating outside the prostate towards the neurovascular bundles, and I will take them from maybe mild to moderate, or maybe they start out with severe ED, but still eventually responsive on PDE5s, and I'll take them into what I could tell them is dense erectile dysfunction. Same thing is often true with salvage prostatectomy as well, and the other salvage approaches. I'm going to talk a little bit about salvage cryoablation because I said it's my preferred approach, at least when the patient is carefully selected and a good candidate for it. Just in basic concept, what you're doing here is you have a transrectal ultrasound guidance to watch ice ball formation. You're putting probes in perineally into the prostate as demonstrated here. And you have a urethral warming catheter that's protecting the external sphincter and the urethra during that salvage cryoablation. When we do modern salvage cryoablation, I would tell you a couple things. I'm treating the whole gland. I do not think, and the cold registry does not think that data supports that you should not be doing partial gland salvage cryoablations. The reason is because a lot of these men were starting out with some degree of impotence, and partial gland ablations did not preserve erectile function. All of them had bad erectile dysfunction after a salvage cryoablation, whether you did partial or whole glands. So you're not doing the patients any favor. You're also not improving continence. Continence rates are excellent after salvage cryoablation, and it doesn't seem to be dependent really on whether you did a partial or whole gland salvage cryoablation. The rates of incontinence are like about 0 to 5%. I would say it's about 3 to 5% is common. But you can, and the data suggests you do worsen oncological outcomes than when you do that. And doing a redo salvage, I think, is a very difficult cryoablation. So you want to get your best treatment as your first treatment in the salvage setting. Modern salvage cryoablation is, as I mentioned, transrectal ultrasound guided, so you can follow the ice ball. Modern salvage cryoablation is using a well-controlled ice ball. That's by a gas expansion with argon as opposed to liquid nitrogen. In the machines that we use at Northwestern, the one that I prefer, the CryoCare machine, there's a slider that allows you to do variable ice ball lengths, so you can sculpt and be away from the external sphincter. You want to use thermocouple monitoring during the procedure. I think the most important probe is the one that you put towards the urethra and external striated sphincter. You want to use a urethral warmer. That's a laminar flow urethral warming during the case. These are outpatient cases, and they take about an hour or so. Here's what the probe looks like. The ice ball is always forming from the tip of the probe and then back. You're using argon gas expansion to get to really cold temperatures as cold as minus 140 degrees Celsius. And because it's the argon gas and they're using this Joule-Thomson expansion effect, as soon as you turn off that gas, the ice ball stops growing, which is great. And a lot of this really prevents treating areas you don't want to treat and having things like rectal fistulas or other injuries. This is the machine we're using. Again, it has those sliders that allow us to sculpt the ice ball. And this is an example. We're doing it as an outpatient setting under general or spinal. You can see the prostate there on the right under ultrasound. We're placing the probes where they are, and then we're freezing the prostate, and the ice ball basically shows up black on the ultrasound. And that's how you can follow it. You can see at the bottom right, we're very far from the rectum there at the end freeze. 2 freeze thaw cycles are used, and so the procedure takes about an hour because those freeze thaw cycles take that time. You need to get temperatures less than 40 degrees Celsius. Just like brachytherapy and other perineal procedures, it's hard to cover the whole prostate when it's greater than 50 cc's. Not usually a problem in the salvage setting, but just note that you're trying to treat that. Procedure takes about an hour, minimal blood loss, obviously. Just note that we're using that urethral warming catheter, so we're intentionally protecting about a 5 millimeter radius around the urethra. So we're not treating disease in that area. Patient goes home the same day. If you give them a BNO at the end of the procedure, then they do not need anything afterwards. They just go home with Tylenol as needed. The catheter should really ideally stay in 14 days. I've had some patients want to take it out early, and almost without fail, when they take it out early, they have some retention issues. And the reason for that is there's not just ablative killing at the time of the procedure, but a secondary inflammatory response that comes in, and it tends to peak around 7 to 10 days and then go away. And so these patients can be a setup for having retention after that, particularly in the salvage setting. Focal setting and primary is a different story. So just in general, as we get towards wrapping up, what are the different modalities? What are the positives and negatives? How do I go about treatment decisions? So salvage prostatectomy, some of the considerations. A big positive is it can treat periurethral disease. It can treat disease involving the seminal vesicles. It can allow for more staging by lymphadenopathy. Negatives is it's potentially the most morbid, having the highest rate of severe incontinence, and having that being fairly common, in I would say 30 to 50% of the patients, even in expert hands. I think it's a good option for people who have periurethral disease involvement, and I think it's a good option for younger men. In my practice, and again, I've only done about 40 of these salvage prostatectomies, but most of the patients tend to be younger men, and my continence rates have been a little bit better. I think mostly because they've been younger men and carefully selected. Salvage cryoablation has low peri-procedural morbidity, very good continence outcomes. I think, again, there's no comparative studies, but probably the best among the salvage therapies and continence outcomes, very cost effective. The negative is it can't treat periurethral disease with the warming catheter. It really, you can't treat distal SV disease because you really are risking ureteral injury with the ice ball growing into the ureters. You can't do a lymph node dissection. I would say still, if the patient appears to be a good candidate for this, disease is away from the urethra, non the SVs, it is my go-to. It is the thing that's going to have the lowest morbidity, equivalent cancer control with well-selected patients. It is my go-to. Salvage HIFU has the advantage that it can treat periurethral disease, but also the disadvantage is that it can cause periurethral sloughing. It has a higher stricture rate, one that approaches salvage prostatectomy, if not more. It can have some issues in treating after brachytherapy. you needing to boost energy around the seeds. HIFU's only been FDA approved even as a modality to ablate prostate cancer tissue. So, cryoablation has been FDA approved for actual treatment in the salvage setting, HIFU just for ablation of tissue. And a lot of us don't have a lot of experience with HIFU. So if a salvage HIFU is going to be performed, really refer that person to an expert, particularly if they had brachytherapy in the past, in my opinion. Salvage brachytherapy has good continence outcomes, but again, you can't do lymphadenopathy just like the other ablative techniques, and there's more limited data on it, in my opinion. As a side note, though salvage brachytherapy after external beam radiation can be considered, I just want to make it clear, salvage external beam after brachytherapy, I think should be at best considered investigational only, and I would actually say it should not be performed due to unacceptable toxicity rates. There was only a small published series of this, and in the small published series, I think there were unacceptable, very, very severe toxicities. I don't know, I'm not trained in radiation oncology. I don't really understand dosing and when tissue gets what dosing, but I would not do external beam salvage after brachytherapy. But salvage brachytherapy after external beam can be done. And there is some questionability, maybe some clinical trials with some of the newer ways that we can give radiation that's more pinpoint. Maybe there is some investigations to be done there. What's the peri and post-operative salvage follow-up? As I said, I only perform salvage cryoablation and salvage prostatectomy, so I'll just tell you what I do in those settings. Salvage cryoablation, catheter should stay in for 2 weeks and then come out. Salvage prostatectomy, I strongly think, and I've seen some of my colleagues, even experts, take out the catheter before 3 weeks, like at 2 weeks, or as if they were, or even earlier. I have some experts when I was down in practicing in other areas away from the Midwest that would take out the catheter just like it was a normal prostatectomy. I think that's a recipe for disaster, and I know that because their patients would then follow up with me later. You really want 3 weeks because healing is going to be retarded, and it's going to just take a while, and you're going to have good scar tissue laid down. And in that vein, do a cystogram prior to every removal in the salvage setting. If there's a question of a leak, even if contained, just leave the catheter in longer, let that seal up. PSA follow-up, similar to after primary treatment. PSA is Q3 months for 1 to 2 years, and then Q6 months for 1 to 2 years, and then yearly afterwards. For the ablative therapies, a nadir plus 2 definition is the commonly used definition of biochemical recurrence, and that's what we use after things like salvage cryotherapy. It's a lot of content, but I hope it was helpful. And in summary, what I was going to say is that recurrences and persistent disease after the initial attempt at curative therapy they're quite common. We're dealing with real disease now. We're surveying the disease that really does not need treatment, and that's a good thing. But as we're dealing with real, prostate cancers that need treatment, in a lot of other malignancies, we often need a multimodal approach to elicit cure. And the same thing is true for, I think about half of the prostate cancers that we take to treatment. So it's not really you shouldn't really think about it as a treatment failure if your primary therapy doesn't work. The patient should be expecting that there's going to be some degree of treatment failure and need more therapy, and you should just see it as part of their care. So it should not give you any inertia to keep working them up and giving them more opportunities for cure. And that means vigilant and workup at early signs of recurrence or persistence. A rule of thumb is if you haven't salvaged someone with a PSA, less than 0.4 nanograms per mil after prostatectomy or less than 4 nanograms per mil after radiation therapy, you really want to take a good look at that patient, a good look at yourself, and say, why have you not salvaged them? Is there a really strong reason? Because the best oncological outcomes are going to happen with those early salvages. Salvage therapies post-radiation have elevated risk compared to when they're performed as primary therapies. No question. Salvage prostatectomy has way more morbidity associated with it than primary prostatectomy. That's not really as true for salvage radiation after prostatectomy. I think that's very well tolerated. But even though salvage therapies like salvage prostatectomy, salvage cryoablation, salvage HIFU have more morbidities when they're performed up front, it doesn't mean we should deny those patients those therapies. In carefully selected patients, for example, salvage cryoablation is cost effective, provides excellent oncological control, good continence outcomes, and really has minimal perioperative risk. And what they're really looking at is severe ED as their major problem, and patients shouldn't think that they have no options, and then you're waiting till their PSA is over 10, and really now you've made it so that they've had no options. I'll stop there. take any questions. I appreciate your attendance tonight. Sorry, I'm in a hotel room. My daughter is moving into her dorm today. I'm actually coming to you from sunny California, but hopefully the reception was pretty good, and I'll take any questions in the last 10 minutes.
Hey, Ashley, hi, it's Ted Schaefer. Awesome talk. I actually have a question for the radiation oncologist. I saw a couple on the call still, I think. I just wanted to get their comments about differences in salvage brachy between LDR and HDR, and if they could just expand on that a little bit, because my understanding of those differences, if they're are very limited. So if anyone could just take over the mic, that would be great.
And also for the rad-oncs to add on that, because in my old group we did have some people who were really expert in HDR. Add on, like, clinical expertise in HDR, what your thoughts are on that, if it is better, like, should we be doing it at Northwestern, that kind of thing. Please go ahead. I see Dr. Sajid, Dr. Hart's on the call.
Yeah, this is John Calipurical. So we've been doing LDR brachytherapy now for probably 15 years. And they're pretty much, it's 6 of one and half a dozen of the other. And there is absolutely no difference. The only reason for not doing HDR is, it is when they are similar, and you're used to doing one, you keep doing it, So there is absolutely no difference in the effectiveness. The long-term data would be with LDR because of the Seattle group and their long-term, Alvaro Martinez and those guys in Michigan and groups in California. Have certainly Syed and others have combined HDR with radiation, and there is a large randomized trial, that Mac Roach has done comparing these, and personally, I think there will not be any difference. Now, in the recurrent setting, I have never done brachytherapy because I personally believe that the brachytherapy doses are very high after radiation, and I'm extremely concerned about both the rectal toxicity as well as the urethral toxicity. So NRG has done a trial showing feasibility in selected patients. I certainly am open to doing it, but all the patients who've come to me, for my opinion, have gone elsewhere for other treatments, because obviously I would disclose fully that this treatment is fraught with toxicity that could be prohibitive with fistula formation and bleeding and retention and necrosis and so on. So that's why I think personally I don't have an experience with brachytherapy, even though there is a body of experience. I just feel that the toxicity may outweigh the benefits.
In my old group, Dr. Schaefer, and maybe I'll get some other opinions. In my old group, they felt similar to what Dr. Calipurical is saying, that up front, LDR versus HDR, not much difference in the primary therapy for outcomes. In the salvage setting, there were a couple in my old group that thought that there was emerging evidence, at least, that HDR might allow for less of this toxicity. I don't know. I wonder if any other rad-oncs have heard of this themselves, but I don't know. But we had a couple providers that really felt that the way the radiation was given, with really high dose and then off, somehow was if your catheters were precisely placed, would be sparing the rectum and the urethra. But it made me very, very worried. Sean, do you have any additional thoughts to what Dr. Calipurical said?
I would probably, I don't do a lot of brachytherapy. The theoretical benefit with HDR is that you can control the dose distribution a little bit better. I have friends and colleagues at other institutions who, are very vocal with that kind of an opinion. As John mentioned, the Rtog has shown that salvage LDR is feasible and largely safe in expert hands. So I think largely it probably matters more, the volume of the person who's doing this. You definitely want to use some modern form of image guidance, which you can do with both. But I don't know if there's enough data theoretically, HDR has some benefit in terms of being able to more precisely control where the dose goes. But, there aren't a lot of crystal clear data that would say that one is vastly better than the other.
Bill,
Hi, I'm a radiologist.
Go ahead.
Hello, can you hear me? Is it okay if I make a comment here?
Please, please.
This is Tarak Batala. I'm a radiologist, diagnostic radiologist at MD Anderson Cancer Center. And we do have a couple of radiation oncologists in our group, specifically doing brachytherapy, specifically LDR. And we have seen a couple of cases where salvage brachy was given for recurrence, both after post-prostatectomy and also following prior combination radiotherapy.
And how's it going? You said it's like, so I think one question I'd ask is, post prostatectomy, why would you want to do like brachytherapy over a traditional salvage external beam therapy? Is there any good rationale? I mean, I think that I know that the disease down there sometimes is severe. There's some people who have played with the idea of like intraoperative brachy even, but why would you want to pick that as a modality? Just educate us a little bit.
Yes, I know these are the cases that I've seen at a tumor board. I don't have any personal experience of having what is the decision process that how that was made, but my understanding is based on the patient preference and also bulky disease at the fossa.
Yeah, and so that actually is interesting. That's an interesting case. I mean, I'm just a urologist, and I know that there's a patient that Dr. Calpuricol and I treat, and Dr. Vanderwell as well, who has a bulky recurrence at the fossa. He came into our group with, I think, some hematuria, the previous radical. And this is just me as a urologist and being a layman. I think that Dr. Calpuricol is going to do IMRT on him, and I think that with the modern technology, I don't know. I just think that we're very good at getting dose where we want it now, and that's one of the reasons that I sort of a favorite. I could see the rationale, and now that you're saying it, if they have really, really bulky, centimeter-sized recurrences. Yes. Putting something in there that kind of makes sense, and I think it was MD Anderson, or maybe it was the Mayo Clinic. Some of their IR doctors are similarly doing stuff with cryo under image guidance. They'll do there's the one negative of the cryoablation machine that I use in the OR is that it's not MRI compatible. The Galea machine has MRI compatible probes. And I think it's the Mayo, or maybe it's MD Anderson, that they're doing.
It's Mayo.
It's Mayo.
It's Mayo because we don't have a big of a cryo team here.
Okay,
but we
perfect.
do have a MR-guided brachytherapy team, and specifically we fuse them with the MR images, and that's the reason we were able to, even in the de novo LDR also, we try to avoid external sphincters and bladder neck, and try to be more precise in terms of placing the seats.
Yeah.
I think I agree that I think Loyola also has a post-prostatectomy brachy program, if I'm not mistaken. My concern, Dr. Bathala, is that, post-prostatectomy, like you heard with all these cases, post-prostatectomy radiation is very tricky. As you saw with Bill Hartzell's case, now if you look at the PET scans and PET staging, you have to treat larger volumes to encompass the disease. And I think, just doing brachytherapy alone, if the patient has a 1 centimeter recurrence, the concern would be that I'm missing all the lymph nodes, like Dr. Hartzell was showing with the perirectal nodes, right? So I think, I agree you may give a biologically higher dose, but you can escalate with the external beam. And my bigger concern is, two things. One is encompassing the lymph nodes that are at risk, because invariably, the majority of patients who have failed radiation in my practice have all failed outside the field, 99%. And where are they failing? Distant bony mets and lymph nodes above, and I treat larger fields. It's a paraortic area. So those are areas that with brachy, And like with smaller fields, you fail even worse. And so my second concern with brachy post prostatectomy is that all you have is a bladder there. The bladder and urethra will get a high dose, and as you know, the dose in the middle of the catheters is the highest. So you have to do some kind of a dose finding expedition to find out the safe doses that can be delivered. And when you have so many, certainly I'm not brave enough to do that when there are so many alternatives that are very viable, I think, but others are obviously doing it, and we look forward to their results.
I agree. These are the sporadic cases and atypical cases.
Yeah, I have to say I appreciate you joining this call. It's nice to have engagement from other institutions. I thank you for being here and for your comments.
Very quickly, I know we're over time, but there's also this burgeoning, there's a growing body of data looking at SBRT in the salvage, recurrent, intact prostate setting, and very preliminary data, very limited follow-up, but that is also something that people are interested in exploring more in the future.
Yeah, I'm just the study that I was talking about that had you may be familiar with it, with the 11 patients. It wasn't modern SRT, but it was they had 11 patients, and 2 of them needed exenerations, because of they thought everything looked good, and then the tissue just fell apart. There's a couple of things I would say. One is a ripe area of research for radiation is actually not only understanding molecularly which cancer tissue is going to respond well or not, but actually understanding which benign tissue, which people are going to be more prone. I don't know how you ever figure this out. Who are going to be more prone to severe, toxicity or or degradation of their non-cancerous tissue. I think that's sort of a very ripe area. I think that until we figure that out, I think one thing we have to say, or as these trials go on, like what you're talking about is, and I hope I showed, we have really good treatment modalities that are just under implemented. If you take cryo, which has been around forever, it's been one of the most misunderstood therapies, I think, in my career. I think there was a period where the urethral warming, and it's because people did the wrong thing maybe. The warming catheter was taken off the market, but people still did the cryos. And then guess what? There were a lot of urethral problems, and then the word got out there that cryo causes urethral strictures and whatever. I haven't had one in my practice, not a single urethral stricture. Then there was I think cryo is easy. Learning curve is 0. I think that can fistulas occur with cryo? Certainly. Do they occur if you're really vigilant and watching things? I've never had one in my practice, not even close. But the word gets out there, and then people kind of dismiss these technologies. And they look for these other things going on. In expert hands, continence rates 0 to incontinence rates. I would say let's not say 0. Let's say 3 to 10% as a aggressive estimate. Rectal fistula rates really have to be in the 0 point something percent if done by an expert provider. And that is the benchmark that you're comparing, adding on EBRT or adding on another therapy, or adding brachy on brachy. And I think you're really playing with fire with those. And I would discourage those trials until we understand, I don't even know what alpha beta means, but until we understand how much dose a particular person's tissue can take. And maybe we'll take doing biopsies. Like I tell you, when I do salvage prostatectomies, I was telling Dr. Schaefer, and I had another case like this a couple of days ago, where if I do the biopsy and the needle, I can feel with the needle that, particularly with the perineal biopsies we do now, I can feel the scar tissue going in with the needle on some of my post-radiation patients, and on some patients I really don't feel that. And the patients where I can feel myself digging through the scar feeling tissue, where the guy I operated on this week, the needle was actually deflecting off of his, it could barely biopsy the prostate because it was deflecting on the scar tissue. Those guys and this guy in the operating room, his tissue was terrible. He really had a severe avascular reaction to the radiation. And there's other patients that don't have that at all. And I think we have to try to figure out that. I think that I'm not sure how to do it. I think that maybe it's going to be clinical documentation and some molecular looking at, but I just, as they go on to try these different salvage modalities of radiation on top of radiation, I think they have to be very careful that the benchmark of safety is, what we showed in this talk, at least, of cryo, and I would be very worried. I'm just very worried. I think, you know, I don't want to be too impassionate about it, but like I'm really worried. And even the first case I showed where they did brachy after brachy, I agree with John. I think that they were playing with fire there. And also, you know, if you did it once and it didn't work, it must have been, if you're excellent at what you do, it must have been because of technical, you know, limitations on the patient side. You know, why you know, do it again? But anyways, I'll get off my soapbox with that. But I would tell you, Sean, if you start one of those trials here, do what you always do and be very, very deliberate about it. And you know, I would just have some caution. Although, as you said, SRT, just like the HDR, may be able to focus energy in a more precise way and avoid some of these problems.
And that's the concept, but I cannot agree with you more. Actually, you know, people have been throwing around, you know, how to treat an, you know, intact prostate recurrence, you know, having perhaps a multi-stratified or multi-group approach through the NRG. And that's, I think, at the level at which it should be done very carefully, with safety being the primary endpoint.
Exactly.
You know, and but just one comment, I can tell you that I have treated now over the last 20 years, probably about 15 to 20 patients with re-radiation after radiation. And we go to doses around 45 to 60 gray, fractionated. And, you know, I have had no problems either with bladder toxicity or rectal toxicity. So what we did, and your patient, Ashley, that he will get the same thing. And I've treated probably 6 or 7 patients where, given what I saw with this radiation, I saw that it was safe. And with a couple of medical oncologists, we started augmenting the therapy with docetaxel weekly. And maybe sometime next year, early next year, I'll be happy to share the data with you in our discussion. And I think I've treated probably 5 or 7 patients now with doses ranging from 45 to 60 gray. They could be post-radiation, post-brachy, post-prostatectomy after radiation. And we've had tumor control in all of them, you know, with just 50 to 60 gray. And one patient, talk of safety, my patient had surgery, radiation, and recurred with the local recurrence of about, and then I radiated him, had a local recurrence, and we re-radiated him. And he had severe urinary problems. We did hyperbaric oxygen, salvaged the urethra, then had a stricture. And in an attempt to relieve the stricture, he had an incision placed and he blew up with a fistula. You know, so I mean, I completely agree. You know that vesico, femoral, urethral, the whole works. You know, so. You know, I think one of the safety issues is after re-radiation, you never do surgery. Never. You can't even cut anywhere near. You have to do a suprapubic, you know. No perineal procedures will ever, because you'll end up with a fistula. That is certainly one takeaway from my experience. I'll stop there. Thank you.
Thank you, everyone. And thanks for staying late. It just shows the interest in this discussion. I think the team here all knows, but we're trying at Northwestern to think about ways that we can flag providers that a patient might have a recurrence early and need further workup. I think that's the key to all of this. You know, early diagnosis and treatment. It's the key in the localized setting. It's the key in the recurrence setting. Thanks everyone again for staying and have a great rest of your day. Thanks, Ted.
Great talk. Thank you. Thank you.